to introduce Bruce Crampton, who will run our next session. Bruce is the Senior Director of the International Outreach for the Catholic Health Association of the United States, responsible for assisting and supporting the member organizations in their outreach activities in the developing world. And he's going to bring this day home at the end of the session to kind of talk about perspectives from different segments and different sectors on how they would address programmatically sustainable development goals. So over to you, Bruce.
Thank you, Renuka, and thank you all. We know that we are now between you and your end of the day. If this were a regular Catholic Health Association event, I would say cocktails, and I think that's actually where we're going next. This session is from other sectors. So we have academia, multilateral organizations, bilateral organizations, and NGO, or a hybrid NGO, that we'll hear from in the approaches that they are taking to have innovative and collaborative opportunities for partnership. As I thought about innovative and caring for the needs, one of the things that I really thought about was the beginning of the Catholic Health Association and the Catholic healthcare in the United States. Over 200 years ago, as there was a great need for healthcare in this country, priests and bishops who were here serving people in places that weren't getting service called to religious orders from France and Germany and Ireland, and they sent sisters here. And they came and lived with and among the communities and developed the health system that is Catholic healthcare today, which provides 1/6 of the healthcare in the United States, has about 800,000 colleagues across the United States, 600 hospitals, and thousands of other facilities, urgent care, clinics, specialty clinics, and long-term care facilities. So it's nothing new for us to be innovative and to look at how we do this. And those sisters came here with very little resources. And I remember very clearly last year in this room when Devi Shetty from India told us, sometime our money makes us stupid. And the sisters were a great example of coming here and trading their care for chickens and eggs and opportunity for the future to develop those healthcare systems that are now 1/6. So we are going to hear first from Paul Clyde and Kathleen Cienko. Paul is with the Ross School of Business at the University of Michigan and the William Davidson Institute, and Kathleen is from the College of Engineering at the University of Michigan. Paul?
So thank you very much, and thank you for the invitation here. I'm grateful to have the opportunity to talk about some of the things that we're doing, and I have to say I'm impressed with how many people are still here given the time of day. So I thank you for that as well. So we're going to do a little bit of a tag team. I'm going to start out talking about university as a whole and the William Davidson Institute, which many of you may not be familiar with. And then I'm going to talk a little bit about some examples from the business school side, and then Kathleen's going to come up and talk about some of the work she's doing on the engineering school side. So the University of Michigan, and part of the reason I'm grateful for the opportunity to be here is because there's a lot of work we're doing in global health, and a lot of it is with some of the organizations in the room. We've done some work with Becton Dickinson, we've done some work with Johnson & Johnson, we've done some work with Novo Nordisk, but we aren't as integrated as we should be. And so I would really like for us, and part of what I've been trying to do since I started at the William Davidson Institute a couple of years ago, was integrate us more into the private sector. As you'll see, that's why we were initially set up. But if you just look through the 19 different schools, so U of M is a very large university, for those of you who are not familiar with it, I think about 45,000 students. We have 19 different colleges and schools across campus, And these are a list of just some of them that are involved in global health. And these are some of them that I'm personally aware of, either working with them or I'm familiar with projects going on there. So we have a lot of work going on around campus. And one thing I want to make clear is what I'm going to be talking about, what Kathleen's going to be talking about, is just some of the work. There's a lot of other work going on that we aren't involved in or that we're tangentially involved in. But there are opportunities out there. And so if I was to leave one message with you, it's that we're anxious and looking for ways that we can work with the private sector more effectively. And if it's not us that is doing it, we can probably direct you to somebody within the university who is in the area you're looking for. So there are some efforts going on at College of Engineering, law school, medical school, nursing school, school of business, information, public health, all focused on different global health challenges. The William Davidson Institute, which you may be less familiar with, was formed in 1992 by Bill Davidson, who was the owner of Guardian Glass, with the purpose of engaging the private sector in the transition economies at that time, so Eastern Europe and former Soviet Union. Since then, it has opened up to all low and middle income countries, but still with the private sector focus. So this is very much in line with what is the mission of the Davidson Institute. We have 5 different initiatives, and each one of them engages research and field work. So our role is we are independent of the university, but we're closely affiliated with it. The chairman of our board is always the dean of the business school. But our role is to engage the university community as well as our staff in issues related to private sector development in low and middle income countries. And one of the initiatives is our healthcare initiative. And it's actually our largest, and within that, we do work in supply chain. Some of the conversations that have taken place today, we've been involved in some of those. Procurement, market dynamics, we've been involved in some of that work as well. But what I'm going to spend my time talking about is the work in delivery. So the work with hospitals and clinics in countries all over the world. And that's an area that's of particular interest to me. So the way we do this at the Davidson Institute is we engage all those different schools and others at the University of Michigan. So we tap, even though we're most closely affiliated with the business school, we do tap into all the other schools around the campus and are engaged in projects with them. So let me just talk about a couple examples here on the healthcare delivery side. One is Ethio-American Doctors Group, which is a group of over 250 U.S. doctors of Ethiopian descent, U.S. or Canadian doctors of Ethiopian descent, who have committed time and money to starting up a facility in Ethiopia. And the goal of this facility will be to offer world-class health care to those within Ethiopia who could afford to go elsewhere, but they want to offer a health care that is going to make it so that they would be willing to stay there in Ethiopia. And the kind of work we do is we partner with all these organizations. So we have a bunch of partnerships. I'm just going to talk about 2 of them in any detail. But our role is to provide them with what they need. And in doing that, we've observed a lot of the things that have been talked about here today. For instance, early on, there was some discussion about the trust and getting on the same page with all the different partners in the relationship. And we observed that in this one. One of the early projects we did there was looking at the governance, because this group was set up, and when I think of governance, I'm thinking of establishing the responsibility, the authority, and the rights to the residual. And I'm not just talking about the financial residual, but also decision residual. And early on, they had an overall idea, but they didn't have a clear picture of what it was that they were going to be doing. And we put a group together that was looking at that very specifically, and that's something that I've observed in the partners we've worked with, especially in the not-for-profit sector. There tends to be a lack of focus on that. They tend to not think about this until too late, and in 2 instances, it almost undermined the hospitals and put them out of business. But as a result of this work, they were able to see some differences they had, and some of the partners ended up dropping out of the work that they were doing. We also did projects looking at the financial viability, doing some basic business planning for them to see where that was going to go. And finally, we did some work on capital equipment costs and needs. So one of the challenges in Ethiopia is they're ramping up very quickly. There was, I forget the exact numbers, but I think it was something like they were buying 30 new pieces of very expensive imaging equipment. I believe it was MRIs over the next 5 years, and they suddenly realized that they needed the people to be able to do the planning for that, the repairs associated with it, get the parts in place, and they hadn't done the work around that. So looking at the total cost structure surrounding the capital equipment as this hospital is planning to go forward. The second example is one that's a well-established system. Aravind Eye Care is a hospital in southern India. Some of you may have heard of it. This past year, I think they did over 400,000 surgeries and saw over 4 million patients. Their mission is to eradicate needless blindness, and we've been working with them since 1999, and we've done a host of different projects, many of them with student teams, but not all, looking at whatever, again, that they wanted, they were working on at that time. So we had a number of human resource projects looking at how do they keep people, how do they retain their best staff. We had some projects on clinical staff, developing metrics for them on their performance. And then we worked on a series of projects with them when they wanted to expand into northern India, looking at how do they transfer their culture, how do they transfer their training opportunities, and how do they do the financial analysis for those projects. And in these and other projects, we've got currently active projects. We've got projects in partners in Rwanda, a few of them in India and Sri Lanka, in addition to the two I mentioned. We've done a number of projects in in Uganda over the years. And one of the things that we've observed over and over is, again, a theme that's come up here, and that is that trust. And it's not, and because we're looking at the delivery level, we're looking at the trust that the patients have in working with the healthcare provider. And we were talking about maternal care. If you're an expecting mother in a village out in rural Uganda and someone comes through and suggests some prenatal care, why are you going to believe them? Why are you going to trust them when they come in and say that? Especially because there have been many people who have come through, many companies have come through before, selling them a bill of goods and just taking their money. And so over time, you have to build up a trusting relationship that's going to make it so that that expecting mother believes you and is going to go ahead and receive that care. And it's not just the patient, it's also the clinicians. So the earlier discussion about ORS and zinc, in Uganda we found there was a study done a while ago showing that I believe it was less than 10% of the clinicians were recommending that to their kids. So if the clinicians are not recommending that, certainly the patients aren't going to receive it. So when we're looking at healthcare delivery, we're not just looking at the technical problems, we're looking at the business model surrounding the whole package and what are the real challenges. And I think a lot of those that have been described here today are some of those that we've identified as well. So anyhow, so that gives you a little bit of idea of what we're doing. I would just say the general view of it from the business school side is we view ourselves as sort of an incubator for business, different business models that might be tried. I've talked about this a lot from the clinic's perspective in hospitals, but we do a lot of work with other organizations as well as looking at what are the revenue generating models, what are the business model challenges that you face in these markets. Okay, now I'll ask Kathleen to come up and talk a little bit about what's going on in the engineering.